The Bobath concept, also known as neurodevelopmental treatment, is a widely used approach in the rehabilitation of individuals with neurological conditions, including stroke. It focuses on facilitating normal movement patterns and improving functional abilities by addressing impairments in posture, movement, and muscle tone. The Bobath approach emerged from the collaborative work of Berta Bobath, a physical therapist, and Carol Bobath, a neuropsychiatrist, who began developing their therapeutic method in the 1940s. The Bobath method is centered on several core principles that guide its application in therapy, including 1. Postural control. Effective postural control is seen as the foundation upon which patients build their movement abilities. The therapy begins with the establishment of optimal postural alignment, which is essential for developing controlled movements. 2. Movement analysis. The treatment involves careful analysis of the patient's movements to identify normal versus abnormal patterns. Therapists focus on facilitating normal movement and preventing abnormal compensatory strategies, which can hinder rehabilitation progress. 3. Sensory feedback. Sensory feedback is crucial in this approach, with therapists using manual contact and visual cues to enhance motor function. This feedback helps patients achieve better control of their movements and supports the reorganization of motor skills. 4. Multidisciplinary approach. The Bobath concept emphasizes a collaborative approach involving physiotherapists, occupational therapists, and speech and language therapists. This multidisciplinary strategy is essential for addressing the diverse needs of individuals with central nervous system impairments. The aim is to facilitate the development of new movement patterns, while addressing any abnormal tone and reflex responses that may impede progress. The Bobath concept has incorporated findings related to neuroplasticity. The Bobath techniques in flaccidity period include 1. Implemented immediately after illness onset, when paralysis and paresis show flaccidity. 2. Focuses on regular position changes every 2 hours. 3. Includes initial class exercises, early walking attempts, and upper-lower limb improvement activities. 4. Incorporates compensatory exercises. The Bobath techniques in the spasticity period include 1. Begins as spasticity develops. 2. Emphasizes progression from sitting to upright positioning. 3. Gradually introduces walking exercises. 4. Includes exercises to normalize muscle tone and inhibit primitive patterns. The Bobath techniques in locomotion stage. Focus. 1. Primary emphasis on locomotion development. 2. Concentrated work on upper limb function. 3. Continues with previously established exercises. Facilitation techniques are integral to promoting optimal posture and movement components necessary for effective functional task performance. Therapeutic handling, which is matched to the patient's abilities, is used to enhance neuromuscular function through the application of sensory information. This includes guiding the initiation of movement, supporting proper alignment concerning the body's base of support, and adjusting the force, direction, and timing of muscle activation. For instance, shoulder retraction and trunk extension are encouraged through head and trunk flexion. The approach emphasizes controlled movement trajectories, such as shoulder flexion from 60 to 120 degrees, combined with elbow extension from 120 to 8 degrees, performed at specific speeds to suppress abnormal patterns and improve joint mobility. Exercises are performed in various positions, including lying, sitting, kneeling, and standing, and particularly closed kinematic chains. For instance, supporting weight through the affected upper limb in different positions helps improve proprioception and shoulder joint stabilization through joint approximation. Key points of control, such as the humerus and thumb, allow therapists to facilitate desired movements effectively. Specific actions, such as thumb abduction combined with forearm supination, facilitate greater mobility and functional performance in the upper extremities, while maintaining an awareness of the individual's current capabilities and fostering independence in movement. In the case of the lower extremity, the therapist may guide the patient to shift weight onto the affected leg during standing or stepping activities. This helps to activate the muscles around the hip, knee, and ankle, promoting better control and stability. Proper alignment of the pelvis is crucial for effective weight bearing and movement. The therapist may use manual guidance to align the pelvis and encourage activation of the core and hip stabilizers. In the context of the Bobath method, inhibition techniques are employed to suppress atypical movement and postural components that hinder the development of appropriate motor patterns. These techniques aim to reduce any underlying impairments that interfere with functional performance. Specific strategies include preventing unnecessary movements that obstruct coordinated actions, limiting the range of motion to ease the force required to maintain posture, and balancing opposing muscle groups. Additionally, excessive muscle stiffness or spasticity is minimized to facilitate smoother movement of the upper extremities. Key points of control are critical in implementing these inhibition techniques. Therapists use their hands to guide and facilitate movement at key points such as the shoulder, elbow, wrist, and hand. Key points of control in the lower extremity include the hip, knee, and ankle. As an example of inhibition techniques, humeral external rotation combined with flexion to 90 degrees is utilized to reduce flexion tone in the upper extremities, while thumb abduction and extension along with forearm supination effectively diminish flexion tone in the wrist and fingers. Additionally, placing the arm in a position that discourages flexosynergy, e.g., shoulder abduction, external rotation, elbow extension, can help break the pattern of spasticity. The Bobath method frequently employs a combination of inhibition and facilitation techniques to address the diverse needs of stroke patients. This dual approach allows therapists to optimize movement patterns and enhance the overall quality of life for individuals with upper extremity impairments. Bilateral activities could be used to encourage the use of both arms together in symmetrical or reciprocal movements that can help integrate the affected arm into functional activities. By continuously assessing and adjusting therapeutic handling, practitioners can improve the efficiency of movement and support the client's ability to engage in daily activities. In the case of trunk muscles, the therapist uses manual techniques to facilitate activation of the deep core muscles, including the transversus abdominis, multifidus, and pelvic floor. This is often done by applying light pressure or resistance to the abdomen or back, while the patient performs small movements, such as lifting the head or rolling. This helps to promote a more upright posture and reduces compensatory strategies. The therapist may use manual guidance to correct common postural deviations seen in stroke patients, such as lateral flexion of the trunk or posterior pelvic tilt. Activities such as reaching forward or sideways while maintaining an upright posture can help integrate trunk control into functional tasks. In the case of gait training, the therapist guides the patient through the phases of gait, like heel strike, foot flat, and push-off, by manually facilitating the correct muscle activations and joint movements. For example, during the swing phase, the therapist may assist with hip flexion and knee extension to prevent the dragging of the foot.